Welcome to This Might Sting a Little, the unfiltered, no-holds-barred medical roundtable from the Vagina Doctor podcast and VD Media. Join GYN rebel Dr. Duncan Turner, regenerative and concierge ER expert Dr. Orel Swenson, and internal medicine maverick Dr. Dennis Hughes as they take on medicine's biggest questions, emerging therapies, and the BS no one else wants to touch. From hormone chaos to longevity hacks, from sex and aging to cutting-edge infusions, no topic is off limits, no ego is safe. And yes, sometimes it might sting a little.
But I want to talk about the things that we use, phrases we use for patients, or things that we're supposed to do for patients that are just unreasonable, inaccurate, not serving the patient best. And so collectively trying to let patients know what we think is the best way for them to talk to their physician and what they should be looking for in a physician.
No, it's totally reasonable.
Sound reasonable? Okay.
Yeah.
Last time we talked, the one that immediately jumps to mind is standard of care. And this is almost a useless statement because it's so vague. There are so many variables that make it almost impossible to do accurately. And if you look at definitions of quality of standard of care, it's basically what physicians are expected to do. That means the average physician. And so is average satisfactory?
It's worse than that, right? Because it's not the average physician. It's also what the population average is, right? So it's the mean plus or minus one standard deviation at best, assuming you believe the standard deviation to begin with, because those are based on the studies that are limited to whatever population they scoped out for that purpose, whether it was overly male represented, overly elderly or young, or any pick a demographic, so to speak. That drove the standard of care definition that we are now adhering to. So plus or minus one standard deviation of that standard of care is totally irrelevant if you weren't part of the initial population demographic to begin with, making the whole thing a joke, as we know.
And if you're looking at statistics, and that's all that people have, that physicians have sometimes, is the statistic of the chances of success or failure of a certain thing. It doesn't really matter to the patient how many thousands were cured by something if they weren't. And so you've got to do the best you can with the best of your knowledge all of the time. So we should be pushing ourselves to do that. And that's just not the standard of care.
No, anyone can test you, right? That the worst part of it is if you deviate from quote unquote standard of care, provide something personalized, now you're outside the scope of it. I'm sure we'll dive into evidence-based medicine and all that kind of stuff, but now you're outside the scope of evidence-based medicine. You're outside what's considered best practice. So if, there's a saying for emergency medicine, right? You can do anything you want so long as you're right. And while that's meant to be a little sarcastic and playful, the idea is you can a patient comes in complaining of chest pain, and clearly it's an anxiety-based issue. It's not a heart attack. It's not a DVT, a blood clot, anything else, CVP, or a blood clot, or anything else. And you choose not to get certain tests and not to get the CAT scan. If you're right, great. But if you're wrong, despite applying a very personalized approach, you've now gone off of the standard of care and you're hung out to dry. So it really hurts us in two ways. And I think this kind of comes back to what we've previously discussed in terms of how malpractice inform our standard of care, how evidence-based medicine inform our standard of care, and how that really means we're pigeonholed to practice very often population-level medicine, because if we go personalized and we make a mistake, we're in a tough spot.
Yeah.
The problem is that, as we all know, studies aren't always well done. Oftentimes they're not well done. They're not well designed. There's not enough people in the study. They drop out, and the studies are of short duration. And we do learn a lot of things on the job. I've been doing this for 26 years. I've learned a lot past my residency. You have to factor that into account.
Absolutely.
The Medical Board of California require, as do most hospitals, continuing medical education. But they're not very specific about what that level, that continuing of medical education is. It may have very little to do with the primary practice of the physician that's getting the credits.
Yes.
And so they learned a lot about something else, but they never do it because maybe it's great, it's interesting, it's new, but they will never apply it in their practice because they don't have the opportunity to do it because this is not the right patient. So continuing medical education isn't the answer to it all either.
Well, for me, actually, the way I'm doing my internal board exams now, my internal medicine board exam is instead of doing once every 10 years mega exam that lasts all day, I answer 30 questions every quarter. And it keeps me up to date in internal medicine. I love that option.
Yeah,
A friend of mine told me
absolutely.
about it. It's less stressful, and I'm refreshing my knowledge base. So for me, I really enjoy that.
You get a gold star for that. It's the way to do it.
I'm glad they're offering it to
Yeah.
me instead of that every 10 years. It's pretty hard to study for every 10-year exam when you're working 10 hours a day.
And a lot of that, in that 10 years of change,
It's
since
changed.
the standard of care is different. It's just you using the
Say
same
that.
words.
You say
It's-
that.
Yeah, I don't have an answer here at all. I just am pointing out some problems that we face as physicians. I really dislike this statement of evidence-based medicine. As we've collectively in our chats at other times have talked about the time from bench to bedside, creation of a treatment to actually being the standard of care for something. On average, that is 17 years. It's a long time for somebody who has the problem on day one to wait for the cure on year 17. That's not, that can be helped a little bit by the method that you're using to educate yourself. But the person that's waiting for the 10-year exam may miss that entirely.
I've never been a big fan of rigid guidelines because often these guidelines are way behind, as he was said, and not every person is going to fit into this guideline. For example, it's often recommended, this is your area, that women post 65 years old no longer need pap smears.
Right.
But 20% or more of new cervical cancer cases are diagnosed 65 and older,
Right.
especially if they haven't had a pap smear in 5 years. Pap smear is uncomfortable, but it's cheap and quick. I don't tell women to stop getting pap smears after 65.
No, but very frequently their internists are, and the patient comes back to me and said, my doc says I don't need that anymore. I saw a patient very recently who had, now we look at two aspects of a pap smear. We look at cellular changes and we look at a DNA evidence of human papillomavirus, which is thought to be the causative factor in 99% of cervical and vaginal cancers. This patient I'd seen every year, normal pap smears, and suddenly at the most recent exam, she was HPV positive. Now, she had no abnormal cells, but she had the causative factor there that could possibly cause a problem unless her body was able to fight it on her own, which would be most likely to be the case. And she said to me, I got it on August 21st.
That date stuck in her head.
Yes, because that was her last sexual encounter from years beforehand. And since that time, I've never had a patient tell me when they got that.
Yeah, to the exact date.
To the exact date. And she was actually laughing about it, that she knew the date. But it's a little off subject perhaps, but the point is that things change. As we know, things change. They may change slowly or they may change very quickly. And it's the decisions that are made, the guidance that is given are often rather silly. There's one other situation that I think relative to a guideline. I saw recently a guideline for labiaplasty in women. That's the only sex that's going to get labiaplasty. And there was a publication by the American College of Obstetrics and Gynecology of the guidelines for doing labiaplasties in women. And if they were less than 18, they had to have a medical reason for it and or a psychological evaluation. And so it's recommended in this guideline that you do those things if you're going to do a labiaplasty on a patient that's less than 18 without an obvious medical diagnosis. The ridiculousness of the guideline is that's against the law. Okay? Why do you have to wait? Why do you have to write a guideline for something that's against the law? It's just, oh, my guideline said it was okay. Sorry, here comes the sheriff. You know, it's the guidelines are based on somebody's feeling, somebody's decision as to how we need to treat people. Most of it is common sense and some good, healthy medical knowledge, and getting second opinions and for things that are unusual.
I think, Dennis, I think you mentioned once before over drinks something about the internal medicine guidelines, but they all couldn't come up to a plan. It was you, I can't remember who. They couldn't come up with a plan. They just decided at the last minute to throw it together and walked out after 4 or 5 days at the conference, something like that.
It was a story I'd heard on a podcast about a conference regarding osteoporosis screening.
That's right.
And diagnosis. And they were trying to figure out what parameters would place you in the category of normal versus osteopenia versus osteoporosis. And the story I heard was that it was just sweltering hot and everybody was exhausted. And they were just trying to hash back and forth what number should dictate which severity. And they finally rushed it and put the figures down, and that's what we go by.
Just call it a day. Yeah.
Yeah. That's good scientific evidence.
I like the thing you said about
leg.
This lady's recent infection with HPV, because that goes to something that's always driven me crazy about HPV vaccination. Insurance will pay up to a certain age. Why is that? Is it the assumption that at a certain age, somebody's had so many sexual partners, they probably have HPV already? What's the point? There's 128 strains of HPV.
Yes.
And 9 of them cause cervical cancer at this point, and
Right.
2 of them most often, 16 and 18. What if somebody was married for a long time, they got divorced at age 50, and they have their second sexual partner? Now, why shouldn't they be protected? I don't get that.
Yeah, that's always been bizarre. Insurance would not cover it for somebody that was under 30 and that was over 30. Just that. This is way back. I thought, why isn't this allowed? Patients wanted it, and they were at risk, and it just didn't make any sense.
And colonoscopies are another modern and very pertinent example for everyone under 40, 45. The rates of colon cancer are skyrocketing, yet insurance companies are not covering it unless you check 1,000 different boxes and get a medical clearance for the risk that you need, that you might have colon cancer at an early age. I'm like, but it's everyone. It's through the roof. And it takes, again, way too long to update the guidelines. And I think, again, this is one of those areas where, recognizing the privilege of operating outside the insurance company, we also have the privilege of actually doing what's right for the patient.
Yeah.
We don't have to wait until you're 45. We don't have to wait until this and that. We're like, this is what the right thing is to do. And this is another area where, the guidelines really burn us, right? They are utilized by the insurance companies themselves, and there's a whole black box unpacked there.
Which we'll do another time.
Exactly, to effectively limit what we can do. They turn the guidelines against the best of patient care. And, getting into the definition of evidence-based medicine, they've really corrupted it. Originally, when evidence-based medicine became a term, it was meant to be 3 considerations, right? It was 1, what was the best research? 2, what was the physician's best acumen based on years of experience? To your point, it's generally considered you're not really a good doctor until you're about 5 years out of residency. That's not meant to knock anybody, but it takes time. You've got to put your reps in. Best clinical judgment plus best research judgment plus what the patient wanted. And somehow we've deleted the other two things. And now it's just, no, it's just research. And it's just not only just research, it's only double-blind, placebo-controlled trials. All of the trials, all of the research doesn't count. We've gotten so narrow spectrum in what we consider good research to advise evidence-based medicine, which then advises the guidelines, which then advises the insurance companies, that we're way off base.
And the results of those studies are usually not black and white.
No,
There's a very number of shades of gray.
So I have a very good, I call him friend/mentor in the biotech space, in the the R&D space for new drugs. And these guys will source and hire and pay top dollar for, I'm not going to use the right terminology, but for the individuals who design the research trials. And I remember distinctly talking, I was like, it is an art, it is not a science. We design a trial to identify the things we want to identify. Hard stop. It's not, to your point, it's not a true double-blind trial. It is manufactured to look for certain things, ignore other things, and reach a certain outcome or disprove that outcome, whatever it may be. But it's a very targeted approach. And that type of research is nonetheless the basis for guidelines and everything else that we do now.
I'm pretty sure if a colonoscopy cost $150, the insurance companies wouldn't care that much.
I don't know. You increase the number of people who can qualify for it by those under 40. They push back on a lot of things.
There was a study out of Canada on breast cancer that was published about 5 to 10 years ago, but it was a 20 or 25-year study. Two groups of generally matched patients. One group had annual mammograms, and they were the control group. The other group were patients that had self-examination and examination by physician. And the results of the study were that there were many more cancers in the group that had mammograms.
Mm.
And the mortality, however, was the same between both groups. And their conclusion was that it didn't matter if you waited until you could feel a lump. Because mammograms have been very good at picking up cancer. But we get a lot of things in there that we don't really need to know and want to know. And so there are a lot of people, a lot of women being diagnosed with breast cancer who have the types of cancer that are not life-threatening. They're not going to progress. They can be observed. But what patient wants to wait when they've had that diagnosis made? So often routine testing is counterproductive.
I mean, the potential counterpoint to that, not that I know the study at all, so speaking way out of my lane here, but is to say, okay, but what was the gold standard for intervention? Were they using cutting edge treatments for cancer in both groups? Were they intervening early? Should they have been intervening earlier? Because it doesn't seem like the mortality rate should be the same.
No, it doesn't.
Is it just that the insurance company said, we're not willing to pay for it just yet? Or we're not willing to put you on this trial drug? Or, again, out of my lane, but that would be my first thought of, are the physicians being handicapped with respect to doing something about these maybe benign, maybe not benign, so we're stuck waiting?
Yeah. I don't know the answer to that. I don't know the details. The point of the study was really to determine whether it mattered if you found it early.
Right.
And I think generally the feeling has been with annual mammography, yes, more picked up, but the death rate is not any higher.
I'd like to see the study.
Me too.
For our next installment, I'll find it.
All right.
But I will add that the only group of physicians and scientists that recommend annual mammograms for the average patient, the radiologist. Every 2 years, by almost every national board of breast cancer evaluation recommends every 2 years, from 45 to 65. But then they stop. And some that varies from country to country. But this is North America, Europe, some strange tendencies.
It gets into the prostate screening conversation, right? Men are now, once upon a time, you would die from prostate cancer. So you would not die from prostate cancer because it's so slow, and you were guaranteed to die of something else, so to speak. But that's very much so no longer true. You can certainly outlive prostate cancer now. And we get, I mean, you would know better than I do as far as what are the guidelines around that, and how aggressive to screen for it until what age and when to pursue interventions, etc.
It wasn't long ago that we were asked not to do PSAs anymore, but I never listened to that. If you have a man who's 60 years old and he has a lot of mileage ahead of him, why am I not going to screen?
Right.
We have prostate MRI now, the gold standard. We can get a good sense of what's going on and how aggressive to be, or just watch. The urologists are practicing a lot more watchful waiting now. I'd rather have my patient know what's going on at least. Doesn't mean we have to do anything right away.
And the treatment isn't innocuous. It's when you've got complications of incompetence, incontinence, and impotence.
But we only get that one beautiful life, so at least I like my patients to know what they're faced with, and they can make decisions with their specialist.
So you two don't know this about me, but I had prostate cancer at 56. Something like that. My father died of prostate cancer. My maternal grandfather died of prostate cancer. So I was watching, and my PSA was fine until it wasn't. But it hadn't gone up above normal. It was just higher than it had been by a significant amount.
So it was below 4.
I had a biopsy, and even the biopsy was a little questionable. And nevertheless, with my family history, I decided to take, at that time, the most frequently used treatment was radical surgery. And I'll just extend the story a little more because I think it's interesting. There was, being in the field of minimally invasive surgery, I knew people all over the world who were developing instruments and doing new operations with what we call straight stick laparoscopy before the robot came along. And I knew some people were doing laparoscopic prostatectomy in the world. The most I could find that anybody done in the United States was 16. And they were just basically trying it on somebody who was beyond surgery, so to speak, or was a candidate that was unlikely to improve otherwise. This was the last shot. So those numbers weren't thrilling enough for me.
No, not at all.
And so I gave up on it and made an appointment to go to UCLA and have a radical prostatectomy. I went to another medical conference in between while I was waiting for the surgery at UCLA. And I ran into some people in the business in Europe, and they said, no, there's this guy in Paris. He's done 300, and his blood loss is minimal, and his success rate is great. I got on the phone, called him up, jumped on a plane, and went to Paris. Never met the guy, met him the night before surgery, and had successful surgery. I was in hospital for 5 days there, but that's a European tendency. Then you stay in hospital for longer than you would do here.
Was the hospital food in Paris good?
Red wine was a clear liquid, so it was okay.
Perfect.
But I've been very fortunate. My PSA has been 0 since, and I don't want to call it a happy ending, but that's
great.
It was good. So it was good. Everybody thought I was crazy. But I was actually back in the operating room, operating myself, doing a laparoscopic hysterectomy 2 weeks after that surgery.
Well, you came right back home. I would have stayed in Europe for a while.
I might have stick around for a while as well.
Actually, I did because it was my mother's 80th birthday a few days later. So I went to a party. Then I came home.
Nice.
But there's so many factors that we have to put into dealing with patients. And we three are very fortunate because we have cash-based practices and we have nobody pushing us to see more patients hurriedly and meeting a quota. We can give the patients the time that they need. And it's a privilege for them, but it's also a privilege, mainly a privilege for us.
Yeah, we have the time to talk about options,
Yeah.
pros and cons of screening, doing anything.
Yeah.
This does open up a different level of complexity, which is to say, for how nice this is, so to speak, I think all three of us would agree this is a departure from the kind of parental approach to medicine that most people are used to. None of us go in the room and say, this is the right answer, this is the antibiotic, and we're done today.
Mm-hmm.
We don't have the answer. We expect a conversation. We expect an informed patient who is actively involved and wants to think through the decision-making process with us and wants to determine their own risk tolerance levels, whatever it may be, whether they're exploring something novel and regenerative, whether they're watching and waiting, whatever that consideration is. And something to also keep in mind that this limits, there is a place for evidence-based medicine. As much as it limits physicians, it also gives a very easy playbook for about, what do you want to call it, half the population, maybe a little less than that, maybe 30%, depending on how you choose to slice that number, so to speak. And there's a lot of people who just want to have an answer. This is not unique to America, although America is also the hammer of let's get it done, move on fast.
Right.
There's something unique to the practice we have here with respect to allowing that patient conversation, but also expecting them to come in informed, with questions, with expectations, with a dialogue expectation rather than an answer expectation.
Here's also what happens. You only get 15 or 20 minutes with the patient. They leave with questions, so they start emailing you. That's why primary care physicians have an inbox of 100 messages or more a day, because they want to continue the conversation. And corporate medicine doesn't care, but this occurs in your evening time answering those questions.
Yeah.
And when they can't hear back fast enough, they come to the ER unnecessarily. That's not a knock on you, that's reality. There's just so many hours in a day, and now they're not sure what to do. So they come to the emergency department where they're sitting 5, 6, 7 hours for something that we think is benign because they don't know if it is or isn't.
Right.
Yeah.
I'm sorry, now I'm sorry. The producer's now asking a question.
Fire away.
You are allowed
I
to.
know. The question I have is, Duncan many times will tell a patient to go to the ER.
How dare you?
What?
That was before 2 weeks ago.
Let's talk. What are the ER guidelines? What are those guidelines? What is? Are there?
Well,
Many. Depends
Yeah.
on what we're doing. Oh, yeah. Because we see everything.
Absolutely.
Yeah. But emergency medicine is a time-constrained environment, which is often a very big departure from how the out-of-hospital world thinks. You come into an ER, and actually covered for a colleague of mine for a couple of days in an outpatient setting here just a few weeks ago. And there's a patient who's, I don't feel as good. It was mentioned that he might have some shortness of breath. And my initial instinct, I'm like, so this guy's got shortness of breath. We should get an EKG, get a trope, do a second trope on top of that, get the x-ray right now, maybe see if he has a D-dimer done. Then we can go for a CT if the D-dimer is positive and the x-ray is negative. Because in my world, I don't see them again. Which is why I follow up with the internist, like, why did you do all these things? Because he said chest pain, and I will never see this person ever again. So my spectrum for a workup, the way I think through things, is markedly different than the outside world, where you have the luxury, so to speak, in a way, of calling back, having another conversation, knowing the person inside and out, knowing if they're honest with you about their medical history. I have people come in and they're doing cocaine. They don't tell me they're doing cocaine. That changes their risk factors for a cardiac event. They're 25 years old with a heart attack. How does that happen? I'll tell you how that happens, but they didn't tell me. And there's a reason that I'm doing all these things. Their internist might know about their drug habits. Their internist might know about all sorts of other things and have a better relationship. So for the ER world, it's a very different thought process that comes into play. It's all based on, I will never see you again, so I better know if you're about to die.
I don't understand this looking down on you doing lots of studies. I appreciate that. Besides, the insurance can't block you from doing whatever study you want to do in the ER. For me, if I have somebody with abdominal pain, they may have a diverticular abscess, but no fever. And insurance has got this grid for what allows them to approve or deny a study.
Yep.
Now, this patient of mine who I want to take care of, they have abdominal pain. I suspect something. And they're delaying me for days. to get a study approved. And unfortunately, and I'm sure a lot of primary care doctors do this as well, I have to send the patient to the ER. And
Yeah.
I'll call the ER and say, look, I'm sorry, but this person needs a scan and you guys can get it approved right away. And they're like, great, we'll take care of it.
Yeah.
Appreciate
No,
it.
exactly. We get it.
Thank
We
you
get it.
for answering Karen's question to me. Because that's the truth.
Very much so.
If I see a patient and I'm not sure what's going on, but there's something happening here, that I need some lab work, or I need an ultrasound, a transabdominal ultrasound, not just a vaginal ultrasound that I have. Okay? It's a matter of, okay, this is on a Thursday night maybe, and I know I'm not going to get a patient into, or there's a good chance I'm not going to be able to get the CT the next day out of the hospital. So if I feel the patient is sick enough to warrant it, that I do not want this patient hanging around overnight with a potential appy, I'll send them to the ER.
But are
And
those the guidelines? That was my question, actually. The guidelines, like for you two, with your patients, are you following a guideline of when to send to the ER?
I think for that, there's nothing written in stone. If the patient's saying they have abdominal pain, you can't be faulted for sending them to the ER. And I have a line I like to use with patients, and I'll say, I can't always tell you what's causing your pain. I'm going to do my best to try to figure it out. But at least you can go get your scan and we can tell you what isn't causing your pain.
Yeah, rule things out.
Yeah. At least bring it down to DEFCON 1.
Yeah.
You know.
It's a fascinating profession to be in, because it requires you to listen to patients, to believe what they say, and also believe that there'll be things they're not going to tell you. And you use your brain and you try to do it as efficiently and humanely as possible. And you're not, in some cases, in fortunate cases, you're not pressured by the 20 patients in the waiting room that are all anxious to see you.
Yeah, I can't go back to that.
We're not there. We're not going to do that. So we're lucky.
Okay, I'll just start on something we talked about recently. I feel like a lot of studies we do for screening, the age at what we're expected to start them on for screening is way too late for me. DEXA scanning,
Without
bone
a doubt.
density scanning is one perfect example.
Right.
Without a doubt.
Why are we starting DEXA scanning at age 65-year-old for a person of average risk? Why don't we start at 45 years old? Get a baseline before menopause age for most women so we can see the change over time. That's just another fine example of how these guidelines just don't make any sense. DEXA scans are not expensive.
I actually heard of a patient that had a full body DEXA and they were charged $100.
That sounds about right. Outpatient DEXA cash basis is usually about $100.
Yeah.
150 is on the higher end.
Why?
There's some fancy machines out there that you might get $200, but it's not obscenely
They're a
expensive.
lot cheaper than I thought they would
Oh
be.
yeah,
Yeah.
yeah. The cheap machines are only $60,000, and I say that not sarcastically. Yes, the machines go up to $200,000, but even that's a relative drop in the bucket compared to a CT or MRI,
Right.
3T MRI or whatnot, where you're in the multi-million range. But again, it all goes back to my underlying belief. I suspect you'd be both hard-pressed to prove and hard-pressed to disprove it, which is to say the insurance companies decide where's the financial cutoff, where's the risk-benefit ratio, where we're going to pay out more than we take in, too many treatments, too many deaths, not enough deaths. It's a math game for them.
Yeah.
And I have no insight, having not been part of guideline development ever, as to whether or not that influences how the new guidelines are structured. So many, but I think to Dennis's point, there's many around screening that why aren't we starting them earlier? And
Is there one, like he said, DEXA?
Oh, there are many.
Yeah, there's too many. Maybe whole body MRI. I think that a lot of the comments around, a lot of the physician fear around that in terms of finding what they call incidentalomas. So you've identified something you don't really know what to do with. Is it cancer? Is it not cancer, et cetera? That could easily be, let's call it fixed by doing tens of millions of scans. We don't have enough data. That's part of why we struggle to know what's artifact and what's real in a whole body MRI. If whole body MRIs for routine screening were insurance eligible and we had hundreds of thousands of patients in the next 6 months to look at, I guarantee you we would know what was real and what's not real pretty darn fast. There's a data gap.
Yeah.
Couple that with some of the emerging kind of liquid biopsy approaches. And again, there's shortcomings in a lot of this, to be sure. But all of it comes down to an economies of scale conversation. That is to say, the more they put through it, the cheaper these things get, whether it's a Grail diagnostic, whether it's whole body MRI. But the flip side of that as well, the more you catch early on, the more expensive that person's care becomes over the course of a lifetime. Because now you have to treat that earlier on and rescan them more frequently and recheck the Grail more regularly. Okay, so somewhere somebody is paying and is doing the math to decide where that cutoff is. And it is not about personalized medicine, I can guarantee you.
I think that's a big part of it. But I think another big part of it is this ideology we still have of waiting for everything to blow up.
Yes.
Before we screen. For example, if you're looking at metabolic syndrome, we have a very glucose-centric way of screening people. We're just paying attention to the fasting blood glucose. Instead of looking at the insulin level, which is going to show you the metabolic stress long before that person has hyperglycemia. And so all these years go by, we're not seeing the problem, and the pancreas is under stress. It's burning out. At some point, it's not going to be able to make enough insulin to meet the demands of the body. Sugar starts to climb. Another biomarker where we wait too long. If somebody comes in complaining of fatigue, or if they just have a visit for a general physical exam, oftentimes physicians are just going to check blood cells. And if there's no anemia, the doctor's going to say, okay, I don't need to check iron. You could easily be iron deficient without anemia. And iron deficiency independent of anemia causes fatigue. When I have patients with chronic, slowly bleeding gastrointestinal lesions, gastric ectasia, and they need periodic iron infusions, they feel amazing when I give them iron. And some of those people didn't have any significant anemia. I did a physical on a middle-aged patient a couple weeks ago, and I checked a screening ferritin, and it was 10. And iron deficiency is colorectal cancer unless proven otherwise in middle-aged and elderly people. And if I hadn't done that, I would have missed it because she was not anemic.
Yeah.
So it's what we talk about a lot. It's just thinking way before.
Even our basic testing is lacking. There are things there that really don't need to be done, and there are a lot of things there that aren't included.
I think the take-home message for the audience, and you're welcome to correct me, is at the end of the day, if you are doing just evidence-based medicine, just standard of care medicine, you're not getting high-quality care, whether you like it or not. You're just not getting high-quality care. And that's to say nothing of getting into even more depth of personalization and customizing it. I mean, your iron storage is a perfect example. It sounds like the majority of people should be getting the iron testing done. That's not even getting into a highly detailed, personalized level of care and what interventions you might do for them. Unless I'm missing the point there.
No, you got the
Absolutely.
point.
So, unfortunate. But yes, so if you're, like, if we'd all agree, if your doctor says, okay, everything is normal based on standard labs, standard of care, standard of this, actually doesn't mean that much.
A quick clinical case. 22-year-old female, seemingly healthy, fasting insulin of 7.1 and POB of 98. Everything else is within normal limits according to the lab. What more would you do for the patient?
She's 22. I would ask parental history for sure. That's a big influence on development of coronary artery disease.
Okay, so there's cholesterolemia in the family.
Any history of vascular disease?
Not that I know.
Okay. Is this patient a person that has good habits? Is this person going for it with a good diet and exercise?
No.
That's the first place I would start. The problem with screening tests like coronary artery imaging is that in a person less than 40 years old, it's not going to show any calcified plaque. That's on the cheaper test that costs $200. You would have to do a coronary angiogram to spot soft plaque on a young person. It's a pretty invasive, expensive study with a lot of radiation. I'd probably start with lifestyle.
Thanks.
Of course.
All right. Interesting. I think, there's so many things that I've changed recently since I've read more about aging and longevity, which is not surprising at 79. It's really looking for things that could have been prevented. And I think, yes, the prostate cancer in my case was huge. So I push guys to do that guideline, which is now, as Dennis said, out of vogue. That's one I changed. And a closer look at lipids and closer look at metabolic disease. I'm okay with waiting longer to do a bone density study, but not to 65. I do it at 50. And because I feel like that's actually where I want the baseline. Because particularly in my practice, that's almost always women. They're going to be short of estrogen shortly, if they're not already. And then they're at risk.
Yeah, 45, 50. I went just earlier than 65.
Yeah.
That's going to be premenopausal.
So those are the three things that I would change. Well, thanks for listening. We're getting really good feedback. We'd really appreciate a review on Apple Podcast, Spotify, or wherever you're listening. Thank you. You can always DM the Vagina Doctor Instagram with any questions or topics you'd like to learn more about, or email us. The Vagina Doctor Podcast. It all starts here.